Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Welcome to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and today I'm answering some of your top fertility questions, and these are voicemail rapid fire answers. So this has been National Infertility Awareness Week, which I know if you've been on social media, maybe you've been seeing some content about it. Infertility can be hard, isolating. I've been through it myself, and I never knew where to go for the answers to the questions that I truly had when I was going through it myself. And that's why I started educating on social media almost a decade ago. And I'm so thankful for all of you who trust and tune in and listen to get answers. These questions are all answers to voicemail, so you can call 657-229-3672 and leave your own voicemail question, and we will get to answering it soon. Again, 657-229-3672. You can also ask questions on Instagram at Monday at nataliecrawfordmd. The Instagram community is fantastic. If you're not over there, at nataliecrawfordmd, every Monday you'll see a question box. Some of those questions go here, and some are answered right on Instagram. Some are also answered in the weekly newsletter, nataliecrawfordmd.com/newsletter, and there you'll find fertility-friendly recipes, fertility Q&A answers, and little pieces of education and fertility in the news so you can keep up with my fertility hot takes. And if you're into more content, YouTube has some great additional educational videos. You can go check it out at nataliecrawfordmd. All right, friends. Well, today we are just going to jump in. I'm going to try to answer as many of your fertility questions as I can, as quick as possible in the next 30 minutes. So let's go.
Hi, Natalie. This is Kim from Austin. Thank you for providing so much information for everyone. I have a question about potentially losing your period after you stop birth control. I did egg freezing last year, and once I stopped birth control, my period went away for several months, and they actually had to give me medication to force it to come back, which it did until I did my egg freezing, and then it went away again, and I had to get medication again before I got back on birth control. I asked my doctor about it, and she said it's nothing to worry about. If I ever want to get pregnant, they can give me ovulating medication, but I just wanted to see if this was normal. So thank you again for the podcast. I really enjoy it.
Hello, and thanks for your question. So amenorrhea, or absence of a period after birth control, can happen, but we shouldn't be so fast to always blame the birth control, especially if it lasts for a long time. Other things can cause amenorrhea as well. So you can have hypothalamic amenorrhea, which is where your brain isn't sending out the right signals to ovulate. You can have thyroid disease, prolactin abnormalities, you can have PCOS, and those are going to be some of your top causes. So if you're constantly using birth control, the reason why it can cause amenorrhea is typically short-term due to inhibition of ovulation, but that should quickly resolve within 30 days or so of stopping the pill. You also can have some suppression of the endometrial lining, which can last longer if you take your birth control continuously. But if you had a period throughout the egg freezing process, I would expect that to come back pretty quickly thereafter. So this is something that I don't really love, the kick the can till later idea that it sounds like you're being recommended right now, because if there's some underlying ovulatory problem, you probably want to know that now. Maybe you want to go back on birth control to not worry about it since you don't want to be pregnant, but knowing what it is going to help you in the long term, because what if there's something you should be doing about it?
Hey, Dr. Crawford, I was calling with a question around tracking your basal body temperature. I know that you've mentioned before that really the sole purpose is around confirming ovulation and ensuring that your temperature is going from under the cover line prior to ovulation and then over the cover line following ovulation. My question is, typically in my luteal phase, I am able to confirm ovulation with a temperature increase, and my numbers are usually all above the cover line throughout my luteal phase. However, they're not super high temperatures. They're usually right above the cover line for the whole 12 to 14 days. So I want to ensure that this is good in terms of, the numbers that I'm seeing in the cycles that are repeating. And I want to ensure that this isn't a true sign that my progesterone is low. Thanks so much.
Basal body temperature tracking, or BBT, is detecting your body's lowest temperature in a 24-hour period. So this is usually in the morning before you get out of bed. Your temperature fluctuates throughout your cycle in a predictable pattern, meaning in the follicular phase it's going to be relatively low, and then it will rise at least 0.4 degrees Fahrenheit after your body starts making progesterone after ovulation. We mentioned the cover line, and this is the method I recommend if you're trying to use BBT to help determine your ovulation. And with this technique, what you're looking for is when your temperature is crossing this cover line. So if you take your temperature every morning, starting day 1 of your cycle, after cycle day 10, look at the chart and determine where the highest follicular phase temp occurred and draw the line there, right at 0.1 degree Fahrenheit above that value. So when your temperature crosses this line, ovulation has occurred somewhere between your lowest temperature and the day your temperature crosses the cover line. That's because when your body sends out the LH surge right around ovulation, your body temperature is going to be the lowest at the nadir. So trying to detect this low to crossing the cover line is going to give you your ovulation day. That being said, there is not a more is more, meaning everybody's going to have a different response. There are so many factors that influence your body's basal temperature. And as long as you're over that cover line, you have this temp shift, that is confirming ovulation occurred. It's not a higher temp is better than a lower temp. So I'm not concerned about where your temp is. It sounds like everything is going fantastic.
Hey, Natalie. I was hoping to get your opinion on taking Clomid. My husband and I are both 30 years old, healthy, and have been trying to conceive for 9 months. My cycle has been regular after removing my IUD, 29 days in length, with ovulation usually occurring on day 18 according to ovulation tests and basal body temperature. So far, we have done hormone testing for me and sperm analysis for my husband. His analysis was normal, with a note of some viscosity. My hormones and labs were within normal ranges, with AMH being quite high at 7.2. Although I'm not worried about my age, currently we are definitely ready for kids and know that we want multiple. My question is, would you suggest or think that going on Clomid could help someone in my situation, given that I do likely ovulate? My main concern with my cycle is that my luteal phase seems on the shorter side, and I do not notice any cervical mucus throughout my cycle. Just looking at options or things that we can do now to increase our chances. Thank you for all of your incredible resources.
So I think the real answer here is, are your periods normal or are they not? Because the whole first part of the call, we said periods are fine and perfectly regular. And then at the end threw in, but maybe they're not because my luteal phase might be short and maybe I don't have cervical mucus. If your period's not normal, we should work up your not normal period. So specifically for concern of a short luteal phase, definitely defined as 10 days or less. But if you're hanging out at like 11, that's not perfect. We really love that luteal phase to be 12 to 14 days. So what does that mean? It could be prolactin abnormalities, thyroid abnormalities, some hypothalamic dysfunction, some low ovarian reserve. At a minimum, need some hormone testing, and not just generic call your doctor, say I want hormone testing, but concern that you could have some ovulatory dysfunction and at a minimum thyroid prolactin. Now, if you have normal regular cycles, you are ovulating, you have normal sperm, you have open tubes, officially you meet the diagnosis of unexplained infertility. Luteal phase defect, in my opinion, is the first stage of ovulatory dysfunction, but if you're still ovulating, should that prevent you from getting pregnant? We don't have a great answer here. It might be contributing towards miscarriage or early loss, but is that enough to say why a young couple may not be getting pregnant? So unexplained infertility is the official diagnosis if you meet that category, and Clomid alone does not hold any benefit in that, meaning somebody's already ovulating, Clomid alone's not adding anything to your treatment plan. Clomid plus an IUI is a different option, so trying to get more than one egg or overstimulation plus the IUI, that can be advantageous for unexplained infertility. Stepping back though, how are you tracking your cycles? What are you using to detect them? Is your luteal phase short? Are you using an ovulation kit? Do we know exactly what day? Are your cycles perfectly the same length? Are they getting longer or shorter? Because you might have some subtle ovulatory dysfunction that needs to be worked up first, and that might be something that would benefit with Clomid. I do prefer to treat luteal phase abnormalities after I've ruled out other causes with low-dose Clomid as a first line versus just adding on progesterone for the luteal phase, because the problem is really rooted in that early stage ovulation dysfunction.
Hi, Dr. Crawford. I've had my AMH and FSH tested twice, 2 years apart. First time I was 29 years old, had never been pregnant before, and I waited to test till I was off birth control for at least 3 months. FSH was 7.6, AMH was 2.73, and I just had those tests redone. I'm now 31, almost 32. FSH is 10.8, AMH is 1.89. So quite a drop in AMH, 30%, and an increase in my FSH. The first test was done at a lab through a provider's order. Second test was a home test. And I was pregnant and had one child between those two tests, but I can't think of anything that should have interfered with the accuracy of that. Stopped breastfeeding more than 6 months ago. I'm just wondering, is there a difference between those two types of tests, a home versus a lab test? Should I repeat that test using the same lab I used the first time to get a better picture? Or should I take that at face value and do I need to do any sort of workup to understand why things have changed so quickly? Thank you so much and hope you can answer my question.
Two things can be true at the same time. AMH is not linear, meaning we do not know that you've had a drop in your AMH linearly. The truth could very well be somewhere in between. AMH does change every month. Remember, when we think about ovarian reserve, I like to use my analogy about the ovarian vault. So if you have a vault inside your ovary where all your eggs are kept, every month you have a group of eggs coming out of this vault, and then one of these eggs is chosen to ovulate and the rest of them die. Well, AMH is made from the cells that surround all of the eggs. And so when you have more eggs in the vault, more eggs are remaining, more are going to come out every month. And it's so fascinating because the vault doesn't want to get empty. And as your egg count starts dropping, just because you get older, fewer eggs start to come out every month. But we have up to a 30% month-to-month variability. And did you hear you just said you had a 30% drop in your AMH? So potentially what we're just seeing is different ends of the same thing, where one is just a higher month and one is a lower month, and the truth is somewhere in between. That being said, that AMH is subtly low for your age. Subtly, not super. And we can't with 100% confidence say that it isn't a real drop, right? Just because we know AMH can fluctuate and the truth may be somewhere right in between, we don't know that there's not a real drop. And when you think about FSH, depending on day of your cycle FSH was checked, that's the more important value. And without knowing an estradiol correlated with that FSH, I'm not sure how to interpret it completely. So cycle day and estradiol are important if you're interpreting FSH. All of that being said, repeating in the same lab is always advantageous. So make sure you're checking on the same day of the cycle. Was it day 3? Make sure you're getting an estradiol with it. Repeating it at the same lab where you had it drawn the first time is going to be the way to draw the best comparison. By no means are you running out of eggs today, but if you are running out of eggs at a slightly faster trajectory, why could this be? How many kids do you want? And could this be something that you might want to work up a little bit further? Those are good questions, but your AMH very well could be higher the next time you check it because it does fluctuate.
Hi, Dr. Crawford. I just started listening to your podcast. It's very helpful. My husband and I recently just started talking about trying to get pregnant. Randomly, I thought of something that happened in college. I tried to do my own research on it, but I'm kind of curious to see what you think. So back in college, I got an STD, chlamydia. I'm not sure how long I had it for. At the time, I was only with my boyfriend. He said nothing happened, but I did have symptoms. Looking back, it is fuzzy because it was 12 years ago. So I did have symptoms, but it's hard to know for sure how long I had it. It was treated, have never had it again. But I guess I'm just curious on if you think that would have caused long-term fertility difficulties. I know they said it can lead to pelvic inflammatory disease and scarring. I don't know if I would have known if I had PID, if my doctor would have mentioned it to me. I hadn't really heard of it. And my doctor didn't mention it to me, so I'm wondering if they weren't really concerned about it. But it does say online that it could be asymptomatic as well. So I guess I'm just curious on your take, just because I know that it's such a common thing for people to get, and I'm just curious on kind of the long-term effects of it on fertility. Thank you so much. Bye.
Having a prior chlamydia infection is a risk factor for tubal disease later on. And even if you didn't have pelvic inflammatory disease, which is an ascending spread, so a chlamydia infection at the cervix is lower risk than if it's spread and it was in your fallopian tubes and around your ovaries, that's PID. Typically, you would know it's usually associated with more pain, high fevers, and not just I got diagnosed at the health center. But if you had any type of chlamydia, sometimes it can spread and go into the fallopian tubes without you knowing. So you are at risk for tubal disease. Not everybody has to get their fallopian tubes evaluated right away, but this is something where with this history, might consider accelerating that workup. So typically, if you're under age 35, we recommend a year of trying before you need to get a fertility evaluation. You can always get one sooner. But if you have any known risks, known problems, chlamydia will be one of them, I might consider getting at minimum a tubal evaluation after 6 months. The tubal evaluation in this case is going to be best with an HSG, hysterosalpingogram, and this is an X-ray dye test. In the X-ray dye test, what happens is a speculum is placed in the vagina, a small catheter to the cervix, and dye is injected while watching with X-rays. The dye will fill the uterus and move into the fallopian tubes, giving us the answer if the tubes are normal and open or if they are blocked or dilated.
Hi, Dr. Crawford. I am calling because I was diagnosed with DOR after I started trying when I was 32, and I'm almost 38 now. And after 4 cycles of IVF, I only made 1 embryo, and I recently had a laparoscopy that confirmed stage 2 endometriosis. And my RE is recommending that I do the Agonomics endotriome test. But in order to do that, I have to do a mock cycle. And I'm just curious from your perspective if that's worth doing since it's a lot of time and money, or if I would be able to do some more endometrial biopsies with my local gynecologist to get some similar results. My RE said that we have a 75% chance of the transfer working, but she said a lot of patients don't like that risk of that other 25%, so they opt for testing. Just feeling a little conflicted about making that choice and spending that much more money and time devoting to that transfer. But since we only have 1 embryo, I think we might have to go that route. And my RE said my prospects for making more embryos is pretty low, given the endometriosis and DOR, especially since I'm about to turn 38. So she said I'd probably have to move on to donor eggs or adoption. So this feels pretty high stakes and just looking for some more perspective. Thank you so much. Really appreciate what you do.
Big hugs. There's no easy answer to what you're going through because we really wish there was something that would just make us feel better and safe moving forward to transfer. I will say that you made an embryo, and so I don't know that it's clear-cut enough to say you can never make another one again, and I would take that pressure off yourself. Secondarily is that doing these endometrial biopsies and these other tests have not shown to improve success rates. And I wish they had. I wish there was more uterine testing we could do before patients underwent an embryo transfer in these high stakes circumstances, because we all want higher transfer success rates. So if it did help like that, we would do it. But it really hasn't been shown to be helpful. And sometimes doing this testing in patients who maybe don't need it can be harmful. Instead, what I would consider is making sure that your protocol accounts into the fact that you have endometriosis. So making sure you have a Lupron base on your protocol. We have more aggressive protocols for recurrent implantation failure, which pre-treat with Lupron for a couple months. And that might be more overkill than you need, but it's in line with what's going on. Meaning if we know we have endometriosis and DOR, why are we hunting inside the uterus for these other factors that are probably not at play? And modifying your transfer based on them might actually decrease your success rates. So I completely understand the desire and the natural urge to test everything, do everything. But we have to remember that in this field, science moves faster than research, and that just because a test exists doesn't mean it can answer the question you have or that it can help you. Sometimes it can actually lead you down a pathway getting you further away from success. So lots of hugs.
Hi, Dr. Crawford. Thank you so much for your show. I really enjoy listening. My husband and I are going to start trying to conceive here in the next month or so. And my doctor is aware that I have PCOS and very irregular cycles. They come maybe once a year, maybe twice, if that. So very, very irregular. She prescribed letrozole and did not prescribe Provera. She told me that I could start taking letrozole at any time if I don't get my period, or if I do get my period, starting it on day 3. Is there a reason that she did not prescribe Provera or progesterone so that I would have a cycle beforehand? I'm just wondering the benefit of taking letrozole on its own versus letrozole with Provera or progesterone, and kind of the reason maybe why she did that, because I don't know if I fully understand. Anyways, thank you so much for listening, and hopefully you answered my question. Have a great day. Thanks.
Provera works at the uterus and letrozole works at the brain to impact the ovary. So letrozole is trying to tell the brain to send out a stronger signal of FSH, so hopefully that FSH will be strong enough to get a follicle to grow and ovulate. Provera is giving your body progesterone, and when you stop the Provera pills, your body senses this drop in progesterone and you should have a bleed. The reason to take Provera before using letrozole is if you've not bled in a while or you have a thick lining. I like to think about it as, getting a nice smooth foundation before you build your house. However, some women with PCOS have a very thin lining. They don't grow a lining. So it's not necessarily quote unquote wrong to just give letrozole without Provera or progesterone. But I only do this in circumstances where I've done an ultrasound and I know somebody does have a thin lining and that it's not something that could be problematic. Because if you have a thick lining already and then you start growing a follicle on it, it might not be at a stage where that's really going to allow for a successful implantation. So we do like to start letrozole typically when you're on your period. And so usually we give Provera to induce it, but it's not aiding your ovaries in any way. So it's not wrong to cold start letrozole if we know you have a thin lining. Hope that helps.
Hey, Dr. Crawford. My name is Tequila. Thank you so much for your podcast. I absolutely love it. I've learned so much about my PCOS and my body. I realized after listening to your podcast how my body actually works and what PCOS actually means. I was diagnosed when I was 16 and the doctor wasn't very helpful. I actually had to basically Google everything I actually learned about it. So I actually have just a couple random questions. My first one is about colonoscopies and pregnancy. So my mom died of colon cancer in May of 2020, and I had my first colonoscopy in July of 2020. I'm due for my next one, July 2025, but I'm also starting IVF in the next couple weeks. So I was told that it's not safe because of the anesthesia. So is it actually safe while breastfeeding? And my next question is about donating my uterus. I know it's a long time from now, but I'd like to plan ahead. So I've looked into being a surrogate, and I've read I can't because of my PCOS. So I was wondering if women with PCOS are able to donate their uterus. Thank you so much again for your podcast, and I look forward to listening to see if you answer my questions. Bye-bye.
These are such unique questions, and I love them, and thank you for all your support on the show. That means so much to me. So as far as colonoscopy goes, you can definitely get a colonoscopy before IVF. We do that all the time. We prefer you not have elective anesthesia when pregnant, but it's not a hard pass, meaning sometimes it is needed to have a procedure done, but it is preferred, if that's the case, to do it in the second trimester. With breastfeeding, yes, depending on the type of anesthesia they use, you might have to pump and dump or withhold breast milk for a short amount of time, but you can still have procedures that have anesthesia. Those really have very, very minor risk. When it comes to donating your uterus, okay, number one, surrogacy is a little bit of an old-fashioned term. We still use it all the time, but surrogacy officially would be when you were inseminated with somebody's sperm and the baby was your genetics and you carried it. And yes, women with PCOS are not good candidates for surrogacy in that sense of the word. However, most of the time people use the word surrogacy when they mean a gestational carrier. A gestational carrier is somebody else goes through IVF and then their embryo is put inside you. You just carry the pregnancy. And women with PCOS can usually be gestational carriers. So you may want to check with the agency or check with a different one because that's not usually a hard no to being a carrier. Having PCOS does not exclude you from donating your uterus if that's something you want to do one day. It is still done only at certain academic centers. UAB in Birmingham and Baylor in Dallas are two places that are definitely doing uterine transplants. If that is something that you want to learn more about, that is an incredible gift. I know some people who've had a uterine transplant because they were born with a birth defect without a uterus, and it's been life-changing for them.
Hi, Dr. Crawford. Just want to say thank you for all that you do. I love listening to your podcast and seeing your weekly newsletter. My question is regarding what you should be doing after an IUI. My doctor and care team is saying to stop all physical activity for 5 days, including intercourse. That just seems odd to me, given that I'm extremely active, and I think sitting at home would be worse than getting out there lifting weights, going for a walk, doing some yoga, perhaps just avoiding heavy, intense cardio. Would love your viewpoint on this. Thanks so much.
I'm not somebody who likes to put a blanket "you cannot exercise" after an IUI restriction on anybody. Even earlier this morning, I was telling a patient about exercise in the luteal phase and recommendations. In general, though, I want to say I'm not your doctor, and there are a few circumstances where I might tell somebody this. So if you had a stimulated cycle, so if you took Clomid, letrozole, or gonadotropins, like injectable FSH, you could be at a risk for ovarian torsion. And if I was concerned all the follicles were on one side, I might tell a patient this. So you need to understand why you got this recommendation, because you don't want that ovary to twist and the blood flow to constrict and potentially need emergency surgery or lose the ovary, because that is a real risk in some circumstances. However, let's assume that's not the case. You just have one follicle, it's a normal cycle. Then no, there's no evidence to say that you can't exercise like normal in the luteal phase. And to your point, it might drive you bonkers to not be able to. Exercise is so healthy for you. It's a great form of stress reduction. What I don't recommend if you are going to move your body is anything that is going to be placing extra strain or stress on your body. Let's remember, in the luteal phase, your body is making a lot of progesterone. That takes up a lot of energy. It's trying to prepare for implantation. And so this is not the time for personal bests, running the marathon, really maxing out, going to fatigue on your weight reps, anything that's super high intensity. So even though I'm not saying don't exercise at all, I do usually like my patients to pull it back a little after IUI or in the luteal phase to support what your body is going through and trying to churn out being a progesterone making factory and hopefully making space for implantation. All right, friends. Well, hopefully you enjoyed learning about some of these fertility facts. These were all really great questions. They covered such a variety of topics, and I think it just really speaks to the fact about how little we know about our body. If you have your own fertility question, I'm going to tell you again, you can ask on the As a Woman voicemail. That's where all of these questions came from. That number is 657-229-3672. Again, that is 657-229-3672. You can also ask on Instagram at nataliecrawfordmd every Monday. Some of those questions will be answered right there on Instagram. Some of them will be answered here on the podcast, and some of them in the weekly newsletter. I love that you gave the weekly newsletter a shout out in your last question. That means the world. The newsletter is really carefully curated to not be spam to your inbox, but answering a fertility question, keeping you up to date with little facts, things like my new book, which is going to be going live for pre-sale soon, The Fertility Formula. I can't wait to share it with you. I've been working for years and years and years to get this book into your hands, and I just can't wait for it to exist so soon. So those of you who are signed up for the newsletter at nataliecrawfordmd.com/newsletter will get early access and some special goodies that will be coming. Thank you guys so much, friends. I'm so thankful for all of you and all of your support. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.